So why do we care about atrial fibrillation? Well, atrial fibrillation is very common. It is the most sustained cardiac arrhythmia. In fact, the prevalence is exploding, and by the year 2050, 16 million patients in the United States alone are likely to suffer from this disorder. In fact, if you live to the age of 40, 1 in 4 of us will develop atrial fibrillation in our lifetime. We of course know that atrial fibrillation is clearly linked to the aging population. Atrial fibrillation is relatively uncommon when in our 30s, 40s, and 50s, but up to 8 to 10% of people in their 80s suffer from atrial fibrillation. But we have a lot more homework to do as clinicians and medical scientists, because although we know that hypertension, smoking, diabetes, all are causes of atrial fibrillation, you see here in the yellow squares, there's 40 to 60% of the cause of atrial fibrillation that is still unknown. So lots of work for us to do. Why do we care about atrial fibrillation? Well, patients care primarily initially because they often present symptomatically. They're tired, they're short of breath, they feel their heart racing, they may be predisposed to heart failure. But I'm not going to address those specific, although important, complications today. What I'd like to discuss are the cardioembolic complications, and that's the devastating manifestations of primarily stroke and systemic embolism. Stroke and atrial fibrillation is a big medical problem, both for patients, physicians, and the healthcare community. Patients with atrial fibrillation are on average 5 times increased risk of stroke, although that risk varies considerably, and I'll spend a lot of time talking about that. And strokes from atrial fibrillation are one of the worst types of strokes to have. They are often fatal, and if not fatal, lead to severe neurologic devastation with staggering personal costs to patients and also to the healthcare community. These are quite common strokes. 1 in 5 or 1 in 6 of all strokes are due to atrial fibrillation, and as we get older, that may creep up to 1 in 4 or 1 or 3 strokes. So how do we prevent strokes? Well, we know when we look at a clot anywhere, whether it's in the brain, it's in the heart, or in the limbs, we know it's made up of both platelets and fibrin. And we've heard some terrific talks today with agents that are used for both of those pathways. And so if we want an antithrombotic therapy, we really have 2 choices, and that's antiplatelet therapy and anticoagulant therapy. And the traditional thinking with atrial fibrillation is that antiplatelet therapy is effective, but perhaps less effective than anticoagulant therapy. And I don't have time to show the data, but it's approximately 33% more effective or so when you compare warfarin, which has been our standard of care for almost half a century, to aspirin, which is the most common antiplatelet agent. But times are changing, and we're going to hear from Dr. Goldhaber a lot of exciting news about some of the new anticoagulants. So it's been known for a long time from epidemiologic research done by many of the people, some of whom are in this room, that there are certain factors that really predispose to stroke, such as mitral stenosis due to rheumatic heart disease, which we don't see very frequently anymore, at least in the United States, prosthetic heart valve, or having a prior stroke. We know that there are some factors that are moderate risk factors, being older, having hypertension, diabetes, or heart failure. And there are some factors that predispose us to stroke and atrial fibrillation, but they're slightly lower risk, being a little bit younger, having coronary disease, and having an overactive thyroid. So many individuals began to think we should develop a simple risk score to help patients and clinicians risk stratify patients, because we know some patients we see are at relatively low risk of stroke and other patients are at unacceptably high risk of stroke. And Brian Gage and some of his colleagues put together a very well-known acronym, the CHADS-2 risk score, standing for congestive heart failure, hypertension, age greater than 75, diabetes, stroke, and TIA. And you get 2 points for having a stroke because that's a really big deal. That predisposes you to a second stroke. And then you see, if you look at the number of points, a total of 6, there's a nice gradation in risk. Patients with a CHADS-2 score of 0 have a stroke risk of approximately 2%. Now, these are per year, it's important to keep in mind. And subjects with a CHADS-2 score of 6 have almost a 20% increased risk of stroke per year. So that's a 1 in 5 chance per year of having a stroke. So now that we know patients are at different risks, how do we decide who to give the therapies we have available? And we know that warfarin, which we've been using since the 1950s, has been the most effective oral anticoagulant, perhaps up until the last 2 to 3 years. And we know when we give warfarin, we reduce stroke by approximately 66%, but we do increase bleeding, and we can increase fatal or life-threatening bleeding. And at least in the early trials, we increase life-threatening bleeding somewhere around 1 or 2%. And as clinicians, we don't like to give a drug if we're going to cause a serious side effect that outweighs their original risk of stroke to begin with. So somewhat arbitrarily, we decided, or my predecessors decided, that the threshold for anticoagulation was approximately 3% per year. So we would anticoagulate everybody with a CHADS-2 score of 2 or greater, and then we'd have to think a little bit more closely for those with a CHADS-2 score of 0 to 1. So the prior guidelines, wherever you were throughout the world, said for patients at high risk, which we'll call CHADS-2 score of 2 or greater, as long as there's not something else we don't know about, they should be anticoagulated. Now, for patients with a CHADS-2 score of 1, for those gamblers in the room, that would be a push. We don't know whether we'd use aspirin or warfarin. It depends on the individual patient characteristics, so there needs to be more work there. And those patients at CHADS-2 score 0 or low risk, we would just give aspirin. Now, the problem here is if you look at the prevalence of the CHADS-2 risk score and you look at the patients who we're defining as low risk, that's approximately 40 to 50% of individuals with atrial fibrillation. So are really almost half of the people that we see in clinic really low risk that we shouldn't be providing anticoagulant therapy? And I think that here is where there's been a real paradigm shift. And you're going to hear from Dr. Goldhaber some of the exciting new advances in atrial fibrillation with the novel anticoagulants. And one of the data I'd just like to share with you come out of the RELY trial, which was studying dabigatran, which is a direct thrombin inhibitor. And you see, if you look by CHADS score, that although patients with a CHADS score of 0 to 1 had lower rates of stroke, whether you were in the dabigatran arm or the warfarin arm, if you look at the dabigatran 150 on the left-handed screen, you'll see that they have the same relative benefit of giving dabigatran compared to warfarin. So these patients still benefited the same from the drug, even though they were at lower absolute risk. But importantly, we know when we give these agents, we increase bleeding. So is it acceptable to push the boundaries and give lower-risk patients potentially a dangerous drug? Well, one of the things Dr. Goldhaber is going to talk to you about is one of the neat features of the new anticoagulants that, although they're as effective or potentially more effective than warfarin, what is, I think, unequivocal is that they're much safer with respect to the primary thing we most are afraid of as clinicians, and that's causing intracranial hemorrhage. And if you look at a meta-analysis which pools all of the data from the trials Dr. Goldhaber will talk about, there's approximately a 50% or greater reduction in intracranial hemorrhage. And so we really need to redefine what we call low risk or high risk and have a better sense of how we predict which patients will bleed. And so there's been a development of a CHADS-2 risk score, which you should sound very familiar. It has CHADS-2 in there, but we've added some of the other lower risk factors, such as female age, vascular disease, and now we have a maximum score of 9. And so we see that we're really trying to stratify those low-risk patients because we've taken those CHADS-2 scores of 0 to 1, which had a stroke risk of 2 to 3% per year, and we've really defined the CHADS-VASc score of 1 of very low risk, 0% at least in the epidemiologic studies it was used at, and it goes all the way up to 15% if you have a high CHADS-VASc score. So the other side of the question, we've spent a lot of time talking about risk prediction for stroke, but obviously we care about the whole patient and we don't want to also cause bleeding. And there are lots of scores that have been out there, like hemorrhages, atria, I'm not going to go through the details, but one of the ones that's emerged kind of as the front runner has been HAS-BLED, and you'll see that this is, again, it's an acronym, hypertension, abnormal liver, renal function, prior stroke, bleeding, labile INR, elderly age, and drugs, and you see the same sort of pattern. And the HAS-BLED score has been defined by about a 3 or greater is high risk, less than 3 is probably lower risk. But you'll see one of the problems. Many of the risk factors for bleeding are the same risk factors for stroke. So the patients we're most worried about having an embolic stroke are the same patients we're most worried about bleeding. So what are we to do as clinicians and patients? Well, I think, and this is my own personal opinion, that we generally are overestimating the degree of bleeding in our patients and are undertreating people who deserve the benefit from anticoagulant therapy. And this is data coming out of warfarin, and it looks at individuals by low-risk or high-risk CHAD score and low-risk or high-risk bleeding. And you can see in almost every scenario it favors anticoagulation. So even patients on the top left corner there that are low risk of ischemic stroke, have a CHADS-2 VAS score of 0 to 2, but have a high HAS-BLED score, so greater than or equal to 3, those patients even benefit from anticoagulant therapy. And so I think this is with warfarin, and I bet when the analyses are done with some of the new agents that are even safer with respect to a net clinical benefit, mortality, ischemic stroke, and ICH, that this will push our clinical thinking even further. So where are we moving? Well, this is a nice diagram by Valentin Kruster that shows that we're taking those patients in the yellow and green that previously were not anticoagulating, and we're pushing the boundaries by really trying to pull out just those CHADS-2 VAS 0 patients that may not benefit from anticoagulant therapy because their risk is so low. And the ESC that we were at in Munich recently, they've been in the forefront of really pushing the new guidelines, and that they've sort of brought it to the next step, where only the CHADS-2 VAS, they get absolutely no antithrombotic therapy, no aspirin, and everybody else gets an indication for anticoagulation. And Dr. Goldhaber will talk a little bit about which anticoagulant we then choose. And so just some concluding slides on the future. I think this has been an incredibly exciting field, but we have an opportunity to do even better. And just like in coronary disease, where we measure troponin or markers of protein in the blood to help us risk stratify, the same can be done in atrial fibrillation. This comes out of the RELY trial as well by measuring troponin and NT-proBNP, which is a protein that we measure for diagnosis of heart failure frequently. That elevations in these markers are very common in stable outpatients with atrial fibrillation. And if you look at the red bars, those patients at the highest risk are those with the highest levels of these biomarkers. And then not only are these biomarkers helpful alone, that when you add them on top of the CHADS-2 score, they predict risk. So if you look at low-risk patients, patients who have a higher level of these biomarkers are at even higher risk. And these markers are complementary. They're additive to each other. So if you have a high troponin and a high NT-proBNP, you're at even higher risk. And of course, there's been an explosion in genetic information, and we've begun to understand that there are certain genetic variants that predispose patients to increased risk. And this is some nice data that looked at chromosome 4q25 and noticed that there was a variant that seems to predict specifically cardioembolic stroke, which we know is a type of stroke from atrial fibrillation. And even perhaps more exciting, and again this comes out of the RELY trial, which was the first novel anticoagulant to finish, they looked at a variant allele that impacted the transformation of the dabigatran pill to the active metabolite, and they noticed that when you have this variant, you have less of the active drug, and you have a lower risk of bleeding. So we look in the red line that if you had a copy of this variant allele, you had a reduction in your levels of the dabigatran in the blood, and that resulted in approximately a 30% decreased risk of bleeding. And you didn't have any offset as far as an increase in ischemic events. And this is really exciting because not only can we use proteins in the blood or genetics to help us refine our risk prediction, but we may be able to determine who will not only benefit from the drugs we have, but who could we provide perhaps safer medical therapy to. So to conclude, the decision to prescribe anticoagulant therapy in all of our patients requires balancing their individual risks of stroke and bleeding. And these new therapies, I think you'll hear more about that, provide the promising of a safer and more effective and convenient anticoagulant therapy. And there's going to be a refinement of risk prediction strategies, and I think CHADS-2 VASC and HAS-BLED are the two most prominent. And with the addition of exciting biomarker and genetic data, we will be able to have anticoagulant therapy available to a broader population who deserve it. Thank you.
One question I had is, it was fascinating to me that with CHADS-2 VASC, we're able to risk stratify patients a little bit better, able to provide some sense of who's at higher risk in that lower tier of risk patients. And I think that it's great that the ESC has thought to adopt that and to suggest that we start anticoagulating some patients that may have been missed by CHADS-2. The real question is, we've for years had trouble getting patients who fall into the CHADS-2 score high-risk category. Practitioners are still very reluctant to anticoagulate those patients, and now we're saying that even lower-risk patients are going to need anticoagulation. What sort of barriers do you think we're going to encounter with that change?
I think it's a great question, because obviously my talk focused on pushing the boundaries even further, and we're actually doing a fairly terrible job with the current state of affairs. Less than half of patients who are eligible by the old system are getting appropriate anticoagulant therapy. And I think it's very difficult, and I think you highlight a point that many of these patients are high risk for lots of things, not only for stroke, but they're frail and at increased risk of bleeding. And even myself, I'm always afraid more of a sin of commission than omission. And so I think if we don't anticoagulate somebody and they have a stroke to atrial fibrillation, it's part of the disease process. But I give someone a therapy and then they have a fatal or life-threatening bleed. There's a tremendous responsibility you feel. And I think we tend to say this patient is too frail and they're too high risk, but I think there's very little data that that's true. And it seems to be we probably should be anticoagulating many more patients we see. And I think it just has to be a fundamental paradigm shift that these are very serious strokes, and preventing them is very easy to do with these new therapies. And the risk of very serious bleeding, not nuisance bleeding, is actually remarkably low.
One last question. Along similar lines, one of the big impediments to anticoagulating patients for stroke prevention in the community is this fear of falls. Even the history of one fall can make clinicians very hesitant to anticoagulate patients, and they may not have a particularly high risk for future falls. Can you speak about that a little bit?
Yeah, it's an interesting, we hear this commonly, and I always find myself a little nervous when someone's using a walker or comes in saying that they fell. And we don't know, but it seems that we overestimate the risk of falls with respect to severe bleeding. And there's an interesting article that I didn't have time to show, but if you do a mathematical analysis as best you can, you literally have to fall hundreds of times before the risk of bleeding from anticoagulant therapy outweighs the benefit in stroke prevention. And so I think that's, you know, I don't know if falling hundreds of times is the right answer, but it's clearly not one or two. You have to be falling potentially 1 out of every 2 days during the year. And so I think it just fits with a lot of the data we've seen coming on and on again, is that we worry too much of the risks of bleeding, and we should be worrying more potentially about the risks of stroke.
That's fantastic. Thank you so much.
Thank you.